This morning we'll be performing the Kimberly-Clark lumbar cool radiofrequency ablation at the L4 medial branch and the L5 dorsal rami on the right side. We will be using the multi-cool module that will allow for multiple lesions at one time, up to 4 lesions at once, which is certainly can be a time saver. The other element that can certainly simplify the procedure is the distal projection of the lumbar cool probe, which allows more of a perpendicular coaxial approach, which is a departure from the traditional means by which we do radiofrequency ablation. In most practices, we require about an 80% reduction in pain following double-blind comparative blocks. Some practices are now evolving towards 50% reduction over one block. To get started, we identify the L5 vertebral body. Then we tilt in this cephalad direction to approximately 28 degrees or so that we are able to line up the superior end plate of L5. Once we've got a nice and crisp end plate, we can oblique in the ipsilateral direction so that the superior articular process bisects the disc. This will allow for that perpendicular coaxial approach. Okay. Right about there. Following skin anesthesia, a radiofrequency needle is placed. You want to try to obtain a coaxial view fairly early on, as major movements as you get deeper become more difficult. Once you've got a good view, you can advance to bony contact. We've got bony contact at this point, and we'll place our additional needle at the L5 dorsal rami. To do that, we'll go into an AP view. We'll probably tilt a bit further towards the head, closer to a 38-degree tilt. Once we've got that, we can rotate in the ipsilateral direction once again so that the superior articular process bisects the disc. At L5S1, this can be a bit trickier because of the sacroiliac and the height of the iliac crest, sometimes necessitating less of an oblique angulation. This would be our target. Oftentimes, the other needle may get in the way of your approach, but this can be managed by either moving the needle slightly or adjusting your angulation slightly. Once again, after local skin anesthesia, an additional needle can be placed. Once you've got a coaxial view, you can advance to bony contact. Okay. Once both needles have met a bony endpoint, you confirm positioning first in AP. In AP view, you want to ensure that your needle is placed at the junction of the superior articular process and the transverse process, which we can confirm here at L5S1. We then return to our previous tilt to confirm that the L4-5 needle was also placed at this junction, which we can confirm in this view. The next view would be a lateral view. This would ensure appropriate depth of the needles. Certainly, being too far ventral may jeopardize your neuroforamina. You want to center the picture so that you have both vertebral bodies that you're working on in the center of your fluoroscopic image. At L5S1, placement looks pretty good. At L4-5, probably advance the needle slightly ventrally, walking it forward to ensure appropriate placement. Once you're comfortable with your placement, we'd remove the stylets and inject an anesthetic mixture. The radiofrequency probes can then be placed. In probably 30 seconds to a minute after the anesthetic mixture is placed, the radiofrequency protocol can be initiated. Certainly an AP view as a final view can be considered to confirm placement once more. You just saw me perform the lumbar cool Kimberly-Clark radiofrequency ablation at L4 and L5. As you saw, the specifics of the procedure allow for it to be performed quickly, safely, and reliably. The distal projection of the probe allows for a perpendicular coaxial approach that simplifies the approach to the procedure. And the use of the multi-cool module allows for multiple lesions, up to 4 at one time, speeding up the process considerably. Thanks for watching.